Daktari, I think now we can move to to how do you manage the condition?
The condition.
Yes.
Yeah. So first of all is to deal with the cause of the hydrocephalus. First of all, to determine the cause.
Yes.
Okay. So, like I told you, the three main groups or the three main causations.
Yes.
You have to do the scans to find out. So that is really one of the management. That is part of the management protocol.
Yes.
And then once we find this hydrocephalus, then the management is divided into two. One is medical management, where we give some drug, and also there's surgical. So in medical, we give some drug to try and reduce the rate of formation of this fluid, cerebrospinal fluid. So there's a drug we can give to try and reduce the rate of the formation. But usually this is usually temporary. The mainstay of treatment of hydrocephalus, especially the one that is symptomatic, is usually surgical. Under surgery, there are two main categories of procedures we do. First of all, there's a first procedure we call diversion of the fluid. Okay, so because this fluid is being produced, but we're having a problem either with the flow, so there's some blockage somewhere, or in the absorption. So we can divert the fluid from the ventricle or from the brain into some other spaces where it can be absorbed.
Within
the body, yes.
Yeah.
So the commonest site of diversion is usually the abdomen. So we put a small catheter into the brain, into the ventricles, and then that catheter, we put it under the skin all the way to the abdomen. The abdomen has a surface where this fluid can be absorbed. So that's the commonest procedure. We call it ventriculoperitoneal shunting, yeah, or VP shunt. So mothers will tell you that my child had a VP shunt. So that is basically what it means. So that pipe, we can also put it in other places, like we can put it in the pleura of the lungs, and we can also put the pipe into the heart. We call that ventriculoatrial shunt.
It will not affect.
Yeah, it will not affect.
In the operation.
We have ways of ensuring that
Okay.
we put it correctly.
Okay.
Yes, and this is usually handled by neurosurgeons.
Okay.
Yeah, so we commonly do those procedures. Yes, so that is fluid CSF diversion, or that fluid diversion from the source.
Yes.
Or where it's circulating.
Yes.
That is the ventricles.
Yes.
Now to another part of the body.
To the drainage.
Yes,
where
it
being
can be drained.
Yes.
Yeah, and usually that is the commonest procedure we can do.
Okay.
There's another procedure we also do, and in this one, we do it mostly when there's a blockage to that path. So there's a procedure we call endoscopic third ventriculostomy. This is a procedure, basically we go in, we make a hole, and going through into the ventricles using cameras, a very small camera.
Yeah.
And then we are able to navigate our way down and make a small hole to bypass the obstruction. And that hole now allows the fluid to come out. Yes. So that is called endoscopic third ventriculostomy. Yeah. So in summary, there's that diversion of fluid, which is the commonest procedure we do. And with that, then you get a pipe. And most of the time, that pipe is permanent.
Okay.
We put it, and we only remove it only when there's a reason to remove it.
Okay.
And then the other procedure is that we call ETV, endoscopic third ventriculostomy, where we use cameras and go make a hole to just bypass the obstruction. Yes.
Okay, I'm imagining that this child is growing up.
Yes.
Again, forgive my ignorance. Is growing up, and you have put the chan, and then how does it depend on the size of it as the child grows? Okay, I know there is hidden growth for the child, but is it adjusted?
Okay.
That's why I'm saying, forgive my ignorance.
Yes. No, it's good because even with the parents or caregivers, when we tell them that we are taking their children for that procedure, they'll ask us, now after, will this thing be removed like after a year or after 5 years so that we put another one?
Yes.
So usually the way that shunt is designed,
probably you could still...
Yeah, so the way that shunt is designed, it's a tube. It's usually a plastic tube.
Okay.
And it can stretch. So it stretches slowly as the child is growing. And most of the time it's a very long tube, so it keeps on stretching.
Oh, okay.
So we usually we have children who are now adults. In the 70s, they had the shunts put when they were children, even some as early as 2 weeks, and they still have the same shunt. Yeah, so it's able to stretch.
Oh, okay.
Yes,
as the child grows.
Yes, as the child grows.
Okay.
Yeah,
so you say that
parents should not be scared. And the other thing I need to say,
yes.
Now when this procedure is done, most of these children now start catching up in terms of growth, because you remember I told you the brain is under pressure.
Yes.
So it's not growing.
Yes.
Instead of growing, the brain is being pushed. They initially had a very thin brain, thin rim of brain. When you take a cross section of the brain, when you do those scans, we see that.
Yeah.
Now, when you put this shunt or this other procedure that I call endoscopic third ventriculostomy,
yes.
So you find that now the pressure on the brain has been relieved. So now the brain starts growing, catch up. And for children, you know, this is one of the the wonders of creation. Children usually catch up so fast. Yeah, so you'll find now they are catching up in terms of milestones. Then slowly, you'll find someone who was not like who was so much behind in terms like of motor. Okay. Like they were not able to stand, or they start slowly with therapy. We work in conjunction with many other colleagues when we're dealing with this. Yeah, so with appropriate therapy, physical and occupational therapy, they start catching up. Yeah, they catch up also in terms of intellectual abilities, because they have issues with intellectual or cognitive. Yeah, you'll find that the other thing maybe I didn't mention, now for older children, sometimes the mother will come and say that this child, I've been told by the teacher, is starting to perform poorly. Yeah, so they're having problems in school. They are maybe concentration, even intellectual in terms of
the grades.
Yes. So, and when now you investigate, you find there's that hydrocephalus. So most of the time they catch up. Yeah, because in the first 10 years of life, there's a period we call, we say that the brain has plasticity. Okay. So when we have some of these conditions affecting the children at such early period of life, when you intervene, there's usually that plasticity, so there's some kind of catch up. They're able to catch up. Yeah.
Okay.
Yes.
So what in essence we are saying is that there is hope.
Yes, there
is a lot of hope
that
management is done.
Yes.
And this child is also able to play with other children.
Yes.
They're able to go to school. They're able to do other things that they may need to do in the farm, in the house. So I'm feeling there's a lot of hope.
Yes. These children usually resume their normal life.
Yes.
You'll find them playing, and children are usually very innocent. They'll not know that they have a shunt, so it's us adults who will keep on getting worried.
Telling them,
but the shunts are usually safe, so they can play, they can do whatever they want to do as children, and
they can play football.
They just continue with normal life. Yeah.
And then again, my ignorance. When the shunt is there and the child is growing. Would it be that now the head will be normal size, or it will still be looking a bit big? Yeah, again.
Yeah, so the head usually is big because of the pressure.
Mm-hmm.
So once you relieve the pressure, then now the head initially will be big. Immediately after surgery, will be the same size almost.
Mm-hmm.
It will reduce a bit,
Mm-hmm.
but then with time,
Mm-hmm.
then as the pressures now normalize,
Mm-hmm.
then the head size becomes normal.
Okay.
So in hospital, we usually measure the head circumference.
Okay.
So we usually use tape measures,
Okay.
and then we measure the size of the head.
Okay.
So when you see these children,
Yeah.
that is some of the things we do every time they come to the clinic.
Okay.
Yeah, you'll see us with tape measures.
Oh, okay.
Yeah, so we're just basically
Tunawapima.
tunawapima tunaangalia the size of the head.
Yes.
Yeah, so most of the time it just goes. The head size does not now start increasing,
Mm-hmm.
so it becomes normal,
Mm-hmm.
unless there's a problem with the shunt.
Mm-hmm.
Yeah, but most of the time now it starts now. The size increases,
Mhm.
and the growth of the head will not be as rapid as
Mhm.
it were before
Oh.
the shunt.
Okay.
Mhm.
So I've heard you mention clinic,
Mhm.
and I'm curious to ask.
Mhm.
So they are supposed to be coming for
Mhm.
frequent clinics?
Yes,
Uh-huh.
yes. They have to come. Yeah, those ones. Once we put the shunt, they have to be coming to be reviewed,
Uh-huh.
and they have to come because we have to assess their milestones,
Mhm.
whether they are achieving their developmental milestones,
Mhm.
because that is extremely important. One of the ways we know that the shunt is not working is when someone who had started achieving milestones well
Mhm. Mhm.
now starts getting regression.
Yes.
So it means maybe the shunt is not working.
Yeah.
Or the other thing that we need to usually check is now the head size.
Yes.
So we measure and see that the head size is now growing at a normal rate.
Mhm.
And the other thing that we'll also note is the other psychomotor skills,
Mhm.
cognitive skills.
Mhm.
So they always need to come to the clinic for checkup.
Mhm.
So we have a protocol.
Mhm.
For example, like immediately after surgery, they'll be in hospital for a few days. Then
Mhm.
they go home. After 2 weeks, they come. We see them. Then if they are normal, maybe after a month. After that, we start increasing the duration or the space between clinic visits.
Mm.
Yeah.
But it seems like when you start with someone,
Yes.
with a child,
Yeah.
you'll walk quite a long journey
Yes,
together
yes, yes,
because
yes.
you want to ensure that everything is okay.
True.
Okay.
Yeah. True.
Now we can probably, before we go to now the misconceptions that are in the community, there is the big head
Mhm.
and there is the small head,
Yeah.
and these two, they are in our communities.
Mhm. Mhm.
And probably you could say something
Mhm.
about the small head,
Mhm.
because you find that there are some people, the head, of course, is not the same.
Mhm.
We have different,
Mhm.
but you find that it is noticeable. It is smaller
Yes.
than the normal,
Than
the what we would call normal.
Yes. Yes. Yes.
Yes.
Yeah, so it's true. There's a normal, and there's usually a normal range. Like when you're born, there's a normal range. So we usually say that when you're born, your head circumference is around 35 centimeters plus or minus 2 centimeters, and that's why you see when children are born, the nurse or the doctor will have to measure the head circumference. So those are some of those parameters that are taken when you're born.
Yes.
Your weight,
Your
the
weight.
weight of the baby,
Yes.
the height,
Uh-huh.
and head circumference.
Yes.
Very, very important.
Mm.
Yes. So hydrocephalus basically means the head is bigger than normal.
Yes.
Yes. And then now you can have smaller than normal head. We call that microcephaly.
Yes.
So micro means small.
Yes.
Yeah, so microcephaly.
Mhm.
And most of the time, there are several causes, and some of the causes that I can mention
Yes,
would
yes.
include intrauterine infections. That's why you see we insist that when a pregnant, the pregnant ladies should always go for routine checkup,
Yes.
because some of these things are screened. Some of these diseases will be screened in the hospital and will be started on treatment early. So infections, we call them congenital infections. They are basically intrauterine,
Yeah.
transmitted from the mother.
Yes.
Sometimes you can have some conditions like poor nutrition, intrauterine poor nutrition. Again, that's why pregnant ladies are advised on nutrition. Usually when they go for those clinics, there's some nutritional advice that's given by the nurses there.
When your weight is taken and you are underweight, I have an experience which I'll share another day. You are underweight, and then you are told this is what you need to do because you are underweight, because you are carrying another human being, and you are also a human being. And at some point, I was as small as 45 kgs, and I was expectant. So I hear you. I hear you.
Poor nutrition. Will, because the brain develops as it's there are cells.
Yes.
These cells are there. For them to divide, they need energy.
Yes.
So they need nutrition. That energy comes from food.
Yes.
So you must eat well. So poor nutrition. So the other cause is usually reduced blood supply. It can occur in the uterus, intrauterine, or maybe during delivery.
Okay.
Yeah, so maybe a child and you've heard of this prolonged
labor.
So.
Yeah.
So they have reduced oxygen into their brain, and then that affects the nerve cells. Yeah. So microcephaly basically means a small head.
Yes.
And why is this head small? Because the brain is also small. Now, for the head to grow, you need that brain to grow. So if there are factors that are preventing this growth of the brain, then it means that the head will be small. Yeah.
Okay.
Yes.
All right.
Yeah. So that's basically that. You've heard of this infection called Zika virus.
Yes, I've heard.
A few years ago, it was news.
Yes.
Because again, it's the same thing.
Okay.
Pregnant ladies get infected, and then they have this virus affecting the growth of the brain. Then they end up with small brains. So most of the time, there are severity or degrees of this microcephaly. If it's mild or a bit moderate, the children can live. If it's severe, then it's usually not compatible with life, because your body functions require the brain. You cannot survive without the brain.
Yes.
You need as much as you need the heart, and the brain is also very critical.
Yes, it is.
For controlling of all body functions.
Yes.
Yeah, so if you have the size of the brain is too small, then you may not be able to survive. Usually, again, the children will come. We do those head circumference and such, those that are born, and then we keep monitoring. And usually, they usually involve a lot of different specialties. So they involve physical therapists, occupational therapists, neurologists. So our colleague neurologists, pediatricians, they handle a lot of these children. Yes.
Okay.
So there's usually no like surgical intervention. Most of the time is we manage them as they come. Yes.
Those ones, they don't have anything to boost the
usually it's just good nutrition, occupational therapy. So they are taught, they'll have delayed milestones.
Yes.
So they're also coached on how to do things. So the brain is also very interesting. You can stimulate it.
Okay.
Yeah, and now that's why we see even sometimes we tell patients you need like physiotherapy when you are being discharged. They wonder why
do I need it? Daktari anataka pesa.
Huyo anataka pesa. Then you tell them
anatafutia daktari mwenzake pesa.
No, go even to your local facility, you have it, but then they are not so convinced, because we usually recommend this because there's that need for stimulation of the brain, constant stimulation. And I said, in these small children, under 10 years, they have that ability to undergo plasticity. So some of these things can be learned. The cells are still dividing. So under right stimulation, those with mild microcephaly, they can do some catch-up. Yeah.
But those with very small ones.
Very small, very severe, it becomes a challenge.
A challenge.
To life. Yeah.
Okay, I think this is really getting the information that is really helpful to our communities. Now, let's go to our communities. In Africa, mostly, I think every disease has an explanation of its cause. So what are some of the misconceptions that are in the communities for the big head or the small head?
So unfortunately, most of the time, most of us are not aware of what is this hydrocephalus. So in the communities, so so when it happens, when you see someone with a baby whose head is big, then people start asking questions. The parents will start asking themselves what has happened, the community also. So some of the common misconceptions would include maybe they were bewitched. Someone, or they'll say that maybe someone had not paid dowry or had not done something, so you've wronged the community or your in-laws. So those are some of those misconceptions. Other people will say that it's contagious or it's infectious. So you'll find people are avoiding that child. You know, in our tradition as Africans, when a baby is born, people will come visit and they'll bring some goodies and such things.
To be happy with the baby.
Yes. So, and that continues like the whole first year, people keep on coming.
They come to
but
see.
When you have a child with hydrocephalus, people will come, maybe the first visit, and then once people start noticing the big head, they may start avoiding. So even the parents are also, they feel ashamed. They'll start hiding their child. When you're going out to the shamba or to the church or to public places, people go with their children to church and such things. But you'll find now this child is being hidden in the house. They're not being taken out. And even in some places, those children will be drowned. I was reading in the olden days, people would have those children maybe thrown into rivers and such, and yet there's usually some intervention that can be done. It's so very cruel. Because now you see people don't want to be associated with, maybe they'll say this was a curse, or it was that people have been bewitched, or it's some evil spirits have been sent and they're in this child. So they'll try to avoid that. They
mostly call the child a taboo child.
Sometimes
this one.
That child is labeled. It's labeled. But I would like to really congratulate the mothers and basically the parents who take these children to the hospital because they do the best to the child. Because we have interventions that can help these children, especially what I've said, the shunting procedures. They really help these children, and they live a normal life or near normal life. So those are some of those misconceptions people have. And these misconceptions are bad because we end up having these children being neglected, and they complicate. They get other problems. So they get medical problems. Like, for example, they can get sores. You know, the heads are so big, and they're always lying on the bed. So they get bed sores, pressure sores on the head. And then because again the burden to the caregiver. So the mother will always be there with the child. They cannot be freed to do other duties. You'll find a mother has a 3-year-old or a 2-year-old with hydrocephalus. You know, by 1 year the child maybe starts walking and such. So the mother can do other things, can go to the shamba, can go to the market, can go to work. But in this case the mother has to be there with the child. So you see now that's a challenge in terms of productivity of the mother. And the mother can't go to work. So they are losing time. And also the complications that arise. So they spend more time in hospital. But once this problem is sorted out earlier, then we see the the results are better. Yeah, so those there are those challenges in our communities. So these the parents or the caregivers who come who notice this early and go to the hospitals, I would really like to congratulate them, and also like to urge the community the wider community, that whenever we notice this, let's encourage the caregivers or the parents to take their children to the hospital for diagnosis, because these are conditions that can be treated, and the earlier they are treated, the better for the community and for the child, because then we end up having everyone being healthy, more time spent doing productive work, less time in the hospital, and the child grows achieving near normal life. Yes.
If you are there as a parent and you have a child like those ones, probably there are things that you can identify as the doctor is talking to us, and you can be able to say, that is what I'm going through. Probably I've seen these symptoms on my child, and this is what is going through. The neighbors even if I am going somewhere, I can't leave my child with a neighbor, and that really brings a lot of emotional issues for the family. I would say that our line that you can be able to reach us on is on the screen, so that you can be able to reach out to us. And actually, before we come to a close of this session, I would request you, probably there is something that you have remembered, or something that you'd like to tell the parents in your closing remarks. Kindly tell us.
Okay, so thank you so much, Jen.
Yes.
So parents and the community at large, hydrocephalus is a condition that is manageable, it's treatable. So anytime you see a child who's having the head growing abnormally large, when you see a child having delayed milestones, or they're having difficulties in terms of achieving the milestones, maybe they have regressed or they have stagnated, or if the child is becoming irritable, the child is complaining that they are losing vision, this is something that needs to be addressed. So you'll find a child who used to sit at the back or in the middle, keeps on moving to the front. That means they are losing their vision. Those are some of the challenges, the complications that are associated with hydrocephalus. A child who comes every day, they're complaining of headaches. Please, let's not ignore that. Let that be evaluated in the hospitals. So kindly take your children to the hospital for evaluation, and will help you in terms of the diagnosis and in terms of the necessary interventions. And once they are diagnosed with hydrocephalus, then appropriate interventions will be done, and these children are able to regain and be able to live a near normal life. So thank you, parents, and thank you, Jen.
Thank you so much. Daktari, I'm so grateful.
Thank you.
This is a lot of good information, and I believe that we are helping our audience, and if they have a question, I'm sure they will be able to get in touch with you.
Yes.
You can share the number that they can be able to reach out to you. It will be running on our screen, so that you can be able to reach out to him. If it is an appointment that you'd like to set with him, you can be able to do that. Daktari, before I do my closing remarks, you mentioned something about the brain tumors. And I'm looking at this camera and saying, and looking at you again and saying, I'm going to invite you again, kindly.
Thank you.
So that you'll be able to talk about the brain tumors, so that we can also enlighten our viewers, so that, because what we talk about in this show, we say that it is your health friend. And the friend can only be, have that relationship if we have the knowledge about one another. And if we can get to help our children, help the community in terms of different conditions that are with us, we'll be able to live healthier lives. And my viewer, I am very, very happy, even as we come to the end of this show. And I'm just requesting you that you can get in touch with us on our number on the screen, and also Daktari if you'd want to get to him. And until next time, thank you so much. God bless you, and have a nice day wherever you are. Bye for now.